Good morning, good afternoon, and good evening. Welcome to the Australasian Pleural seminars for the month of June. Today, we are extremely honored to have Professor José Porcel to come and talk about heart failure pleural effusions. So heart failure pleural effusion is the most common cause of pleural effusion. It's probably relatively the most understudied and underpublished in investigations. Professor Porcel does not need much introduction. He's one of the world experts in pleural diseases. He's based in Spain, and he has published extensively on all aspects of pleural diseases. But in particular, he's the leading figure whenever we come and talk about heart failure pleural effusion. So we look forward to a concise summary of what is the latest and on heart failure pleural effusion. So over to you, José.
Thank you, Gary, for inviting me to this to participate in these Australasian seminars on pleural diseases. And for the next 15 minutes or so, I will briefly discuss the diagnosis of pleural effusions secondary to heart failure. I will concentrate on the diagnosis aspect rather than therapeutic aspect because you have a previous seminars by Dr. George that address the management of recurrent transudate and discuss the reduced study. So heart failure is the most common cause of pleural effusion. In our experience, with more than 7,200 pleural effusions submitted to thoracentesis, heart failure accounted for approximately 1/3 of the cases, followed by malignant and infectious pleural effusions. And obviously, heart failure is the most frequent cause of transudates, justifying more than 85% of the cases. Cardiac pleural effusion, despite being labeled as benign, has significant mortality. Approximately half of the patients die within 1 year of diagnosis, based on our experience with more than 1,000 patients, which is supported by other studies. Pleural effusion is frequent in patients with acute decompensated heart failure and is present in 2/3 of patients when ultrasound is used for detection. But what is the most effective method for identifying a pleural effusion of cardiac origin? Can basic clinical data be utilized without resorting to thoracentesis? Should the ultrasonographic characteristics of the effusion be considered? Is the macroscopic appearance of the fluid relevant? Can the fluid be classified as a transudate using light criteria? Should serum or pleural concentration of natriuretic peptides be measured? Or is it necessary to consider a combination of these factors rather than any single one in isolation? We will comment on each of these diagnostic procedures in the order shown in the slide. So what about basic clinical data? Pre-thoracentesis clinical presumption of a cardiac effusion based on the knowledge of the history, physical examination, basic laboratory data, and chest radiograph is not the answer to the question. With this information, clinicians were able to anticipate the presence of pleural transudates in only 56% of the cases in this study. Therefore, we often discover an unexpected transudate when the pleural fluid is aspirated, and these radiographs are examples of patients with unanticipated transudates. Why is it difficult to identify heart failure clinically? And this is because of two reasons. First, physical examination alone is not sufficiently accurate for diagnosing heart failure, with individual findings such as an S3 gallop or elevated jugular venous pressure having moderate specificity but low sensitivity. Moreover, it is increasingly recognized that the presence of more than one etiology driving fluid accumulation is not uncommon. In this series of 126 patients, dual or multiple cause for unilateral pleural effusions were present in 30%, with heart failure frequently being considered a contributory cause. In contrast, multi-organ ultrasound demonstrates a substantially higher diagnostic accuracy than physical examination. Multiple meta-analyses have reported poor sensitivities of 80 to 90% and specificities of 85-95% for ultrasound in the diagnosis of acute heart failure in patients with dyspnea. For example, if we observe an effusion accompanied by a low ejection fraction of the left ventricle or a dilated inferior vena cava with poorly collapsible, the likelihood of heart failure significantly increases. In patients with cardiac amyloidosis, preserved ejection fraction and left ventricular hypertrophy are typical. With regard to ultrasound, this study designed an ultrasonographic scoring system called DUETS to differentiate exudate from transudates. The presence of two or more of the following ultrasound features dramatically increase the likelihood of exudate: the presence of diaphragmatic nodularity, unilateral effusion, complex non-septated effusions, pleural thickening, and septations. DUETS perform better than light criteria in differentiating exudate from transudates. But note that the presence of only one of these ultrasound findings, which mean a total score of 1, could be compatible with a cardiac transudate. And these are two cardiac pleural effusions, despite being ultrasonographically complex septated in the left image or complex non-septated in the right image, in which a swirling pattern can be seen. The gross aspect of the pleural fluid does not yield useful diagnostic information regarding the transudative or exudative nature of pleural effusion, and the truth is that only 13% of transudates exhibit a watery appearance. So we arrive at light criteria, which are well known to all and still represent the gold standard for discriminating exudate from transudate 53 years after their discovery. According to light criteria, transudate, which means heart failure in clinical practice, must not meet any of the criteria shown on the slide. Light criteria have a sensitivity of 98% and a specificity of 71% for identifying exudates, which means that approximately 30% of cardiac effusions are misclassified as exudates. In this unpublished study, we have shown that the triple combination of LDH greater than 250, cholesterol greater than 55, or protein greater than 3 in pleural fluid is not inferior to light criteria and has the advantage of not requiring a blood sample. However, the dual combination of LDH and cholesterol in pleural fluid, although slightly more specific, had a significant lower sensitivity, and this critical shortcoming means that this combination would overlook a greater number of exudates, rendering it less suitable for clinical use. But we still have a problem with light criteria or alternative criteria. We do not identify a significant number of cardiac effusions as true transudates. Is the measurement of natriuretic peptides, NT-proBNP, secreted by the myocardium in response to mechanical stretch the solution? We were the first to describe the usefulness of NT-proBNP in pleural fluid to identify cardiac effusion 20 years ago. And since then, several publications have corroborated our findings. This meta-analysis summarizes the good operating characteristics of NT-proBNP in pleural fluid and serum, approximately 90% or more sensitivity and specificity. However, these data are based on a relatively small number of patients, and the optimal cutoff point has not been established. So at this point, I would like to present to you the largest and most comprehensive study that have addressed the problem of differentiating cardiac from non-cardiac effusions in a series of 2,000 patients divided into derivation and validation cohorts. We developed a scoring system called BANCA based on the following variables: presence or absence of bilateral effusion on chest radiographs, patient age, pleural fluid concentration of NT-proBNP, pleural fluid concentration of cholesterol, and the serum to pleural fluid albumin gradient. And the probability of heart failure increases, and consequently, additional points are assigned if the patient presents with bilateral effusions, is of advanced age, exhibit elevated pleural fluid NT-proBNP concentration, has reduced levels of cholesterol, or demonstrate higher albumin gradients. The scoring system ranges from 0 to 13 points, and with the best cutoff of 8 points or more, we were able to identify cardiac effusions with a sensitivity of 91% and a specificity of 87% in the validation cohort. How does the BANCA score compare with other methods for the recognition of cardiac effusions? If we look at the areas under the curve, the BANCA system is the most discriminative, statistically outperforming other parameters such as light criteria, pleural fluid cholesterol, protein or albumin gradient, NT-proBNP in serum or pleural fluid, a score that we described in 2018 that did not take natriuretic peptides into account. And I would like to point out that we demonstrate for the first time that NT-proBNP in pleural fluid is more effective than NT-proBNP in serum for labeling heart failure, with the statistical differences in the areas under the curve. But the BANCA score is applied to any pleural effusion to select which one might be due to heart failure, and we now know that it's highly accurate for this purpose. But let's now consider only patients with pleural exudates according to light criteria, which obviously include heart failure. How does the BANCA score work in this particular population? In this group, obtaining 8 or more points identified more than 3/4 of cardiac effusions with a specificity of 90%, which was higher than that of the classic albumin or protein gradients. This is the scoring system that we previously described for application in circumstances where natriuretic peptides determination is not available. It included parameters in order of weight, such as age, an albumin gradient greater than 1.2, pleural fluid LDH, bilateral pleural effusion on radiographs, and protein gradient greater than 2.5. And the best cutoff point was set at 7 or more. However, we have just seen that the BANCA score is more accurate than this other scoring system. So let me change the subject and briefly discuss the acute treatment of cardiac pleural effusions. I would like to introduce a couple of ideas. First, the treatment of symptomatic heart failure entails different medication classes, not just diuretics. For example, patients with reduced or mildly reduced ejection fractions should be treated with 5 medication classes, which may be initiated simultaneously at low doses or sequentially. In the case of heart failure with preserved ejection fraction, the evidence is less and include at least diuretics and sodium glucose co-transporter 2 inhibitors. The second, more controversial point is whether therapeutic thoracentesis should be performed in patients with acute decompensated heart failure. The TAP-IT trial investigated the effectiveness of upfront therapeutic thoracentesis plus standard medical therapy versus standard medical therapy alone in 135 patients with acute heart failure, low ejection fraction, and no massive pleural effusions. And the results showed no significant difference in days alive out of the hospital over 19 days, which was the primary endpoints. No difference in the 90-day mortality, 13% in both groups. No difference in the length of hospital stay, 5 days in both groups. And thus, the study concluded that routine thoracentesis did not improve the outcomes in this specific population. However, the study has important limitations, such as the lack of quantifications of pleural effusions. The lack of benefit may be due to the fact that the number of small effusions was significant. We don't know. No data were provided on the optimization of decongestive therapy. No data were provided on the recurrence of effusions. The follow-up period was short, 3 months, and important endpoints such as immediate improvement in dyspnea were not evaluated. And finally, we cannot extrapolate this data to patients with preserved ejection fraction, who represent half of all patients with heart failure, or to patients with very large effusions. In fact, in this retrospective study of 373 patients with heart failure, therapeutic thoracentesis significantly improved the functional class as assessed by the New York Heart Association scale, and this improvement lasted for weeks or months. Also, this multi-center Japanese study, which enrolled more than 3,000 patients with heart failure and pleural effusion on admission to hospital, showed that the cumulative 1-year incidence of the composite outcome of death or heart failure rehospitalization was significantly higher in patients with residual pleural effusion at discharge than in those without, 50% versus 32%. And therefore, the authors were in favor of depleting the patient with therapeutic thoracentesis during hospitalization. So, the key points: 1, pleural fluid only triple combination, protein greater than 3, LDH greater than 250, and cholesterol greater than 55 is diagnostically equivalent to light criteria for separating exudate from transudate with the advantage of avoiding a serum sample. Number 2, ultrasound should be incorporated in the evaluation of pleural effusion. It is more accurate than physical examination for labeling cardiac effusions. Number 3, in order to diagnose cardiac effusions, it is best to use a scoring system that looks at several factors, for example, the BANCA score. And finally, therapeutic thoracentesis may be indicated in patients with symptomatic effusion, despite the findings of the recent randomized trial. Thank you very much for your attention.
Okay, thank you very much, José, for a very comprehensive review and with a lot of latest data. So that's very exciting. Let me start by asking the audience, if you've got any questions for Professor Porcel, please type it in chat and we will read out your questions for you. But let me kickstart by asking, do you think that those N-terminal proBNP and any of those scores actually have prognostic value rather than just diagnostic value?
Well, probably yes, because we have a number of other conditions such as pulmonary hypertension, pulmonary emboli, that in which NT-proBNP measurement has prognostic is a prognostic factor. So probably yes. I don't remember any study concentrating on this aspect, but probably yes. A higher NT-proBNP is prognostic.
Yeah. And we now find that increasingly we are seeing pleural effusion is not one pure cause and is often multifactorial. And do you find that the N-terminal proBNP or any of the fluid markers may be diluted if there's a concurrent second cause? Well,
it is very common to see patients with pleural effusion with dual causes. For example, we see a lot of patients, obviously older patients with infections, for example, a pneumonia, a parapneumonic effusion, and they have elevated concentration of NT-proBNP in pleural fluid in the cutoff of heart failure. But in fact, the fluid is an exudate with a polymorphonuclear predominance. So probably there is a mixed cause. It is very common, especially in older population.
But what I'm trying to say is that if there's the two causes, would the cutoff be different because you got
Yes.
a oxidative mixing?
Well, this is because we have recently changed the cutoff for NT-proBNP. Initially, the cutoff was 1500, but for these studies, we selected very well the patients. I mean, we excluded patients with dual causes.
Yeah.
Now we have mixed all the patients, and the cutoff has been raised to 2500.
Okay. So I need to start changing today. I'm still using 1500.
Yes.
Okay. There's a question about what is the role of pleurodesis or IPC in this kind of heart failure cases? You mentioned the trial showing that therapeutic drainage is not useful, but there are lots of these patients that keep coming to hospital.
Yes. Well, in patients with recurrent heart failure effusions, obviously you may opt by IPC or therapeutic thoracentesis. In fact, both strategies are good for relieving symptoms. The only question is if you need to perform an aspiration every week or every 2 weeks or even every month, probably it's better to offer the possibility of IPC. But therapeutic thoracentesis is okay. We perform IPC in cardiac effusions when the patient needs frequent aspirations, and obviously the patient is okay with this maneuver.
Yeah. Do you think that there will be impact on the severity or the incidence of heart failure pleural effusion now that we've got all the new drugs like the SGLT and all those other drugs? Anecdotally, people say that there are fewer heart failure effusions.
Yes, probably yes. In fact, in the randomized trial that I mentioned, the number of patients, the percentage of patients who fulfill the correct medical treatment was less than 40%. So in clinical practice, we see patients treated obviously with diuretics, but they lack, especially in low ejection fraction patients, we lack another family drugs, which are very important to decongestionate the patients. So yes, we need to improve the medical treatment in all these patients.
I think a lot of the people in the audience probably do not necessarily have N-terminal proBNP in their facilities. What would be your next best option?
Well, I offer you the alternative scoring system. Yes.
Yeah.
Yes. This is quite good. In the order that I put of the area under the curve was the second best system.
Yeah.
Greater than any individual factor. Yes.
Would you use BNP if you don't have N-terminal proBNP?
Well, we don't use BNP because a long time ago we demonstrated that probably NT-proBNP is best than BNP. There are another natriuretic peptides which are similar accuracy than NT-proBNP, like MR, AMP, but at least in Spain, it is widespread the use of NT-proBNP rather than BNP. Maybe in other countries it's different. So you need to use another cutoff points, which are totally different than NT-proBNP.
So there's also a lot of people in the audience who have a research interest. Can you tell us what you think the field of heart failure effusions will be going in the next 5 or 10 years? What do you think is, if someone's going to do a PhD on the topic, what do you think is the most exciting part to do it on?
Well, I think a randomized controlled trial, like the randomized that I presented, but in different way. We need to test patients with preserved ejection fraction. In fact, most of the patients that we see, at least in internal medicine department, not in the cardiology department, are patients with preserved ejection fraction. In these cases, the medical treatment probably is not optimized. We need to demonstrate that the performance of therapeutic thoracentesis during hospitalization have some benefits. And I'm convinced about this, have some benefit about the immediate relief of dyspnea. And I don't know, like the Japanese study showed, that there are some prognostic consequences. But I think this is a gap that we need to fill. I mean, I'm convinced that, in fact, we perform therapeutic thoracentesis to all patients with symptomatic cardiac effusion in our hospital, to all patients. So, but we need to demonstrate this, and obviously it's not easy. But concentrating on preserved ejection fraction.
Okay. So there's a question online. Along those lines, how many thoracentesis would you do before you considered IPC?
Well, usually, it depends not on the number, but on the frequency of recurrence. Because you may have some patients that need one therapeutic thoracentesis every 6 months, every year. This is okay. But if the patient needs every 3-4 weeks a thoracentesis, probably I will put an IPC.
Yeah, okay. And do you think that with the older populations that everyone lives longer now, that we're going to see more heart failure?
Yes, obviously. The median age of patients with heart failure in our hospital is 83 years. So we have patients very, very old with symptomatic pleural effusions. So yes, it's an etiology raising.
We often get very frustrated because the doctors managing the patients with pleural effusions are not aggressive enough with their diuretic or medical therapy and keep doing a lot of drainage procedure for the effusions rather than, at least in our view, being sufficiently aggressive with medical therapy. Do you have the same experience?
Yes. The problem is that we are dealing with older population. They have many adverse events with diuretics, renal failure, for example. And in this way, I think therapeutic thoracentesis may help to improve things. Another important thing is that we never stop anticoagulation in patients with heart failure, which is very common, to perform a therapeutic thoracentesis. It has been demonstrated in the literature that there is no major adverse events. So this is important also. Yeah.
And I think Dr. Sanchez has asked a question that I think we briefly touched on too. If pleural effusion in heart failure is merely a marker of congestion, does it play an active role in the progression of cardiopulmonary dysfunction?
Yes. Cardiac pleural effusion is just a marker of congestion, effectively, and this is because it is important to use the ultrasound also, because the patient is under diuretic therapy, and sometimes we see patients with a small quantity of pleural effusion, but in fact the inferior vena cava is not so dilated or so collapsible, so the patient is okay.
Excellent. Okay. I think we are almost on time now, so I think we've covered a huge amount of grounds. And thank you very much, José, for joining us and teaching us on heart failure effusions. And thank you for those who have logged on, and we look forward to seeing you again in the next episode of TAPS. Thank you, everyone.
Thank you, Gary. It's a pleasure. Bye-bye.